All right, guys, you made it to the end. So we've gone through, this is going to be our part 5 of the cardiac rhythm interpretation course. So we made it through the first couple of sections. We talked about basics and background, atrial rhythms, junctional rhythms, ventricular rhythms. Now we're going to talk about heart blocks. Heart blocks, I think, are one of the hardest things for people to understand. I really struggled with them early in my career, and I did several different EKG classes and always really had a hard time with understanding the differences, and we get them confused. I'm hoping that this will be helpful. There's a really fun way to try to remember heart blocks that I'm going to share with you at the end of this. But it is a challenging aspect to EKG rhythm interpretation. So if it takes you a while to really master this piece, that's very common for a lot of people. All right, so let's just jump right in. So the first one we're going to talk about is a first degree heart block. And that's when the electrical impulses are slowed longer than normal at the AV node, when they're moving from the atria to the ventricles. And this is seen on the EKG as a prolonged or a longer PR interval. So essentially what's happening, let's look at our EKG. So we have our P wave, but now see how long this is? This is taking a really long time to actually get that impulse from the atria, the P wave, all the way to the ventricles to get that QRS complex to come up. So what we're going to see when we do our 5 steps is we usually have a regular rhythm. The rate tends to be about 60 to 100, but it can be a bradycardia with a first degree or a tachycardia with a first degree. So keep that in mind, that can be flexible. P wave is going to be upright and present because this is stemming from the SA node. But her PR interval now is long. So it's greater than 0.2, greater than 5 small boxes, right? Greater than 1 big box. And that's abnormal. I mean, look at this one. It starts at one of the large boxes. It's almost 2 large boxes. I mean, that's huge. So that is your first degree, prolonging the impulse between the SA node to the ventricles. That AV node's holding on to it for too long. So we can see this in patients that are on chronic medications like beta blockers or calcium channel blockers, patients with a history of MI, rheumatic fever, cardiomyopathy, myocarditis, congestive heart failure. It can be congenital finding. Most patients don't have symptoms and don't require interventions, and it can happen in healthy people. It will require some monitoring, but rarely any interventions, and we would only need to intervene if the rhythm devolved into a worsening block. All right, second degree type 1, also called Mobitz I, also called Wenckebac. So 3 names which can make it confusing. Second degree type 1. The AV node is progressively delaying the conduction, which can be seen as a progressively increasing PR interval. And this is going to progress until the QRS complex is dropped completely, and then the cycle repeats. So the PR interval gets longer immediately prior to the drop beat and shorter immediately after the dropped beat. So the phrase that we use to remember this is longer, longer, longer drop. So PR interval, normal. Longer, longer, P wave, nothing after it. So it took so long to get through that it never actually got through. Now it starts over again. Normal, longer, longer, drop. So longer, longer, longer drop. Then you've got the Wenckebac. It's silly, but it works. All right, so similar causes as with the first degree. Medications like beta blockers or calcium channel blockers, history of MI, rheumatic fever, cardiomyopathy, myocarditis, CHF. Patients might present with fainting, dizziness, fatigue, dyspnea, and/or chest pain, depending on how severe this block is for them. A second degree type 1 is less serious than the second degree type 2 that we're going to talk about in a minute. However, all patients should be monitored for their individual response. And we would treat the underlying cause if possible. And if the patient experiences symptomatic bradycardia, we would follow ACLS algorithm and provide pacing if needed. So that's second degree type 2, Mobitz II. This is a block where the impulse coming from the atria are intermittently blocked when they reach the AV node. So this is represented by non-conducted P waves without the accompanying QRS complex. And this can happen intermittently, which is what we see here, or it can be in a pattern. So we could have, like, say, 2-1 conductor. So let's talk about this a little bit. Right, so we've got a P wave, and this PR interval actually looks pretty good, right? Normal. So P wave, QRS complex. P wave, nothing happened. Impulse was totally blocked by the AV node. Okay, never got sent down. But this next P wave, he just chugged on again. Oh, there's a complex. P wave complex, P wave, no complex. P wave complex, P wave complex, P wave, no complex. So in a second degree type 2, the impulse moving from the SA node to the ventricles is being blocked intermittently. So it's not that progressively longer, and then suddenly it doesn't get through. This is just, yep, you go through, and you, nope, not you. You go through, you go through, you go through, you go through, nope, not you, nope, not you. You go through, nope, not you. So we don't really know when it's going to happen, which makes it more dangerous, right? Because in the second degree type 1, Mobitz I, Wenckebac, that all being one name, we can kind of see when it's going to happen because it gets progressively longer, and then the beat drops. With this, beat can drop anytime because the AV node can just block it. All right, so we can see this in patients that have had an MI, severe coronary artery disease, digoxin toxicity. Patient might experience fatigue, fainting, dyspnea, dizziness, chest pain. This for them, again, is less common than the second degree type 1 that we had just reviewed, but is more likely to progress to a third degree heart block. We're going to talk about third degree in a minute, but I'm going to explain to you why it's likely to progress. So we're talking about how it's intermittently blocking. Well, in a third degree, it's just a full block. Nothing gets through. So that's why it's really easy for this heart block to devolve into the worsening heart block of degree heart block, because we're already halfway there. We're blocking half of the QRS complexes and we've got no reason why. But we don't know when that block is going to be permanent instead of intermittent. So there is a high risk that we're going to devolve into a third degree. Treatment for a second degree type 2 is based off the patient assessment. Can follow ACLS guidelines if needed. We can consider a pacemaker if the ventricular rate is too low and causing poor perfusion. So if you think about it, let's say you're dropping more than half of your beats, right? You may still have a little bit of atrial kick, but that is not going to get you where you need to go. You need to be having these full QRS complexes. So when I look at this, I'm actually only seeing a rate of about 50, which for a lot of people is not going to be enough, especially when it's trying to be 2, 3, 4, 5, 6, 7, 8. It wants to be 80. Right? That's where all these P waves, they're sending out impulses saying, hey, I should be beating, like we're going on a good schedule, and only 50 are getting through. That's not okay. All right, so that's third degree. So the third degree is also known as a complete heart block, and that occurs when the AV node is completely non-functional. The SA node continues to send out impulses causing atrial contractions, but then the electrical impulse moves from the atria to the AV node. Nothing gets passed from the AV node. So then what happens? The ventricles start to beat on their own because they think everybody above them has failed. Because even though the atria are going and the ventricles are going, you know how hard it is to do one hand faster than the other? Jeez Louise. So even though they're both working, they're totally blind to one another because the AV node has stopped communication between the two. So what we're going to see is we're going to be able to tell an atrial rate and a ventricular rate. And you can actually, this is how you tell it's a third degree. If you march out your P waves, they're consistent, march out nicely. If you march out your QRS complex, it marches out nicely. But what you'll see is that your P waves and your QRS complexes have no relationship to one another. So that should be your first clue. Even if you said here, oh, maybe that's a first degree. When you look at this next one, well, that's too close. Oh, that one's far again. There's no heart blocks where it varies that quickly, right? And your other big clue is that these QRS complexes are wide. So you know they're coming from the ventricles. Why would they come from the ventricles? Because these QRS complexes don't know that these P waves exist because the AV node blocked off all communication. All right, so some causes. History of infections such as rheumatic fever or myocarditis. Medications like beta blockers and calcium channel blockers, digoxin toxicity and MI, history of cardiac surgery. These patients can be hemodynamically unstable, might experience severe hypotension, syncope, death. Other patients may have minimal symptoms such as dizziness or weakness. It depends on how their ventricular rate is, how quickly the ventricles are responding to this in trying to keep up that cardiac output. Third degree heart block can devolve into cardiac arrest and death. We want to follow ACLS algorithms. Now, epinephrine and atropine tend to not be effective as these work more on the upper part of the heart to stimulate the ventricles. But because there's no relationship now between the top part of the heart and the ventricles, this method of treating the low ventricular rate doesn't really work. So if you were to give epi or give atropine, what you'd probably see is your P waves would increase. But because that stimuli isn't getting down to the bottom portion of the heart, it's not going to do anything for your ventricles. So transcutaneous pacing is really our primary option in this. Works really well. Just remember that once your patient starts confusing again, once you start getting that cardiac rhythm, cardiac output up by increasing their heart rate, they're probably going to need some sedation. So just keep in mind that while they may be minimally responsive when you start, by the time you get them up to a well-perfusing rate and improve their blood pressure, they're going to be getting more oxygen and blood nutrients to their brain, which is going to make them wake up, which is probably going to make them need sedation because transcutaneous pacing, from what I hear, is not very comfortable. All right, so that's a lot. It's really hard to remember all of this. So I found this a long time ago, and I really, really liked it because it helps me to remember all of the differences between the heart blocks in more of a fun way. So think of heart blocks are like a relationship. So in sinus rhythm, you've got the P and the QRS, they're dating and they never leave each other's side. In a first degree AV block, the P and the QRS have had an argument, and so they're starting to keep their distance from one another. In the second degree AV block, Mobitz I, Wenckebac, the P and the QRS are in this vicious cycle of breaking up and then getting back together. Once they get back together, they start to fight again. So then they start to increase their distance again, and then they break up, and then they get back together and they're good. And then they start to fight again and separate, and then they break up. So that's our second degree type 1. Our second degree type 2, Mobitz II, the P and the QRS complex decide to work it out because they have PVCs together. However, the P is still upset at the QRS and goes out a night or two a week, and kind of goes around, right? So you've got P waves with no QRS complex because the P is leaving that QRS at home sporadically, but we don't really know when that's going to happen. And then our third degree heart block, the QRS catches the P having an affair and moves out, so they separate, and so they have no relationship with each other whatsoever. Now I get it's a little cheesy, but it really helped me to remember the different types, not get them confused. So I think it's kind of a fun way to review it. All right, let's do a couple of practice. So looking at this first one, are we regular or irregular? Well, I would say we seemed pretty regular. There should have been a beat here and there wasn't. So let's keep marching. Probably should have been a beat here and there wasn't. So, all right, let's put a pin in that. What's our rate? Well, our rate looks to be about 60 because I see 60 QRS complexes in my 6-second step. So I have a P wave for every QRS and a QRS after every P. So I've got a PQRS, 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 P, nothing. PQRS, 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 P, nothing. All right. What about my PR interval? Well, this looks pretty normal. All right, let's look at my next one. Well, that one looks longer. The third one looks even longer. And now I have a P wave with a dropped P. Then PR interval looks normal again. This one looks a little bit longer. This one longer again. P wave with a dropped P. QRS complex, nice and narrow. So I know that's not coming from the ventricles. So what do I have when I have a progressively longer PR interval until I have a dropped P? I have a longer drop. Then I have the Wenckebac. So this is a second degree type 1, Mobitz I, Wenckebac. All right, how about this guy? I would say that we are pretty regular. So that sounds good. Our rate is about 60. I do see a P wave before every QRS complex, but my PR interval looks pretty long. So if I measure it, let's see, here's a big block starting here. So if I measure that, it's almost 2 large squares. So I mean, that's pretty high. It looks like we counted it out, about 9 small boxes, well above the 5 small boxes that's considered normal. But our QRS complex is nice and narrow. So what do we have when we have a consistently prolonged PR interval with every beat? Now this is just our straight first degree heart block. All right, last one. Are we regular or irregular? Well, these QRS complexes seem regular, so I guess that's a place to start. What's our rate? It's only about 30. So there's only 3 QRS complexes, so our ventricular rate's only about 30. So that's pretty low. We have a P wave with every QRS and a QRS with every P. All right, let's see. So I see a P, some distance. Here's a QRS, but it looks like there's a P kind of buried right after that QRS complex. Another P, and then a QRS, but it's such a wide QRS, it doesn't really make sense with these P waves, right? And then No, I don't really think there's a relationship between these two. It looks like they're both functioning independent of one another. I can't assess a PR interval because nothing's consistent enough. I mean, I could try to get a PR interval here and here and then maybe here, but it doesn't really make any sense why it would be that erratic. And my QRS complex is huge, massive. It's really wide. So I think this is coming from the ventricles. But how can I have this coming from the ventricles if I have P waves? It tells me my SA node is working. Well, my AV node has failed me. So while my SA node is working and sending impulses, my ventricles aren't getting it. So they're trying to do it on their own. So what happens when there's no relationship? You've got a 3rd degree heart block. All right, guys, congratulations. You completed all 5 parts of the cardiac rhythm interpretation course. If you have any questions, please reach out. There's some really great references here on the screen for some practice to be able to work through these rhythms. The skill set one is really awesome. You can actually play it as a game, and so it'll give you rhythms, and as you kind of go through it, it wants to see how quickly you can identify them, but there's also a learning one where it'll give you more information about each rhythm, and so you can kind of understand it a little bit better. So really awesome resources to use. And I'm really glad that you stuck through it and watched all 5 parts. And I appreciate you watching. Thanks.